in this area of research. Thank you very much, Tron.
Thank you, Esteban, and thank you, Armando, for inviting me to this very nice meeting and a very nice city. So I'm enjoying learning some Spanish too. Thanks a lot. This is just a picture of my hospital, and these are my disclosures. Not very many, but there are a few. I want to emphasize what has been said on previous talks and from the two previous speakers as well, that the major concern with PTDM is not actually the microvascular disease developing or retinopathy, which is a diagnostic criterion for HbA1c in type 2 diabetes. It's the cardiovascular disease. So PTDM is the condition at high risk of cardiovascular disease. So we all agree upon that. And every move we make in treating this patient is to prevent PTDM, and if PTDM is there, lower the cardiovascular risk. This is an old pie chart. It's been published several times. All the risk factors that you can find, some of them are to the left, many of them are ordinary type 2 diabetic risk factors, some transplant-related risk factors, infectious risk factors, magnesium. But the most important part is the one that you have touched upon already, the immunosuppressive drugs, most of them with diabetogenic effects. And there is an interplay, as we have learned from the Tenerife group, between those and the metabolic state of the patient, especially obesity and dyslipidemia. This is a previous treatment algorithm that was suggested from the consensus meeting in Vienna back in 2013, published in 2014, and also adopted with some practical things from our own review. Usually what we have been doing up till now is to keep the patient who develops high blood sugar in the early weeks after transplantation at pretty much normal blood sugars with insulin treatment. We don't call it post-transplant diabetes before at least an elapse of 3 months. This is, we give dietary advice, encourage physical activity, and we try to maintain glucose at an appropriate level. Now, after the second, or in the second month post-transplant, we taper prednisolone. In our group, we taper it down to 5 milligrams a day. We don't withdraw prednisolone for a reason I'm coming back to. And if immunological risk allows it, we have been used to use low doses of tacrolimus. I will come back to this algorithm in the end of my talk to see how this could be reversed in light of new knowledge that we have also heard today. We considered withdrawal of insulin and, if needed, start an oral hypoglycemic agent. The recommended goal of HbA1c is in this ballpark. And the drugs that we have been using up till 2014 at least were glinides, neteglinide or rapaglinide, some in favor of metformin if GFR allows it. 2 or 3 years ago, we got reports on pioglitazone and gliptin, sitagliptin and vildagliptin that could be safely used in the reports coming out in 2013, 2014. Now, this is the old algorithm. I'll come back to that. Just one point on steroid withdrawal. There is no trial, there are several randomized controlled trials, no trial have proven that withdrawing prednisolone completely prevents development of post-transplant diabetes. In some cases, it may actually exaggerate the risk or increase the risk for rejections. And there has to be made some point to this. We did a study a long time ago, back in 2004, this was published, that if we do a euglycemic, hypoglycemic clamp in patients with different doses of prednisolone, and even down to no prednisolone, there is an improvement in insulin sensitivity from 15 milligrams per day to 10 milligrams a day, from 10 milligrams a day to 5 milligrams a day, but from 5 milligrams a day to nothing, there's no improvement in insulin sensitivity. And we believe that there's not much gained on withdrawing 5 milligrams of prednisolone as compared to just using it. It may protect the patient from transplantation, so we still use the 5 milligram dose. The old DIRECT study published 10 years ago told us that tacrolimus could be more diabetogenic than cyclosporine. At that time, nobody of us cared about metabolic syndrome, high triglyceride, whatever. There was an OGDT performed in European and American countries, and they found that the P was Fortunately, for those who produce calcineurin cyclosporin, was 0.046. There are a couple of points to this study, which has been sort of adopted as a proof of concept that tacrolimus is more diabetogenic than cyclosporin. One is that the TAC levels in that study were very high. We used 10 to 15 trough TAC levels for months after transplantation. The other part is that nobody cared about hypertriglyceridemia, as has so elegantly been developed the concept by the Tenerife group. So we have to be aware of that the drug both has a dose-dependent effect and it may work differently in different patients who are differently predisposed to diabetes. One question that arose today was, does weight mean anything for the diabetogenic effect of tacrolimus? Yes, after transplantation, yes it does. This is a study performed 3 months after transplantation, but we see the same thing 1 year after transplantation. We do a visceral adiposity calculation from a DEXA study. We do bone densitometry studies and we calculate visceral fat from that. And if we categorize the patients in our study, this is 150 patients undergoing renal transplantation, those with the lowest amount of visceral fat tend to be normoglycemic, but they become impaired glucose tolerant and diabetic if the visceral fat increases. And this is probably the most sensitive metabolic signal that you can see for developing dysglycemia, because you don't see the same thing if you just measure BMI on these patients. So abdominal fat is very important in the interplay between tacrolimus, as all these patients were treated with, and the development of dysglycemia. Just a couple of words on the study that Armando mentioned, the Wissing paper. The first paper actually is that randomized patients with PTDM to continue either with tacrolimus or switch them to cyclosporin. There were 80 patients altogether randomized to the 2 treatments, and the major effect could be seen reasonably in those patients who had a diabetogenic OGDT but were on no other hypoglycemic treatment. But you can even see that in patients on insulin and oral agents. So in my mind, and with all the experimental studies that have been shown us, and several studies coming out, I think it may be time to change the algorithm from just losing low dose of tacrolimus, maybe in some patients to switch from tacrolimus to cyclosporin. I'll come back to that. We are all waiting for the Vienna study, saying that if you use intensive glucose regulation with insulin for the first few weeks, the first 3 weeks after transplantation, in this group, you may prevent the development of PTDM or actually need of treatment for PTDM 1 year afterwards. This was a pilot study with only a few patients. There's a larger ongoing study, but we haven't heard much about that yet, but we are looking forward to see the result, whether intensive insulin treatment to begin with after transplantation can prevent PTDM in the long run. Now to the glucose-lowering agents. This is a figure that I have adopted from Stephen Kahn, published in Lancet, on type 2 diabetes. The historical evolution of all the classes of glucose-lowering drugs that we are using, sulfonylureas, metformin, insulin, and you can see all the new names with an exponential curve here over the last decade. PTDM, post-transplant diabetes, is a very special group with high cardiovascular risk, multi-pharmacy, immunosuppressant drugs, infectious diseases, reduced GFR in renal transplant recipients. We cannot extrapolate all the studies in type 2 diabetes to treating post-transplant diabetes. So we have to look at a few and rather small studies that till now have shown us that it's safe to use the different drug classes in our patients. Till now, we have had small safety studies on DPP-4 inhibitors, at least sitagliptin and vildagliptin. The glinides I mentioned to begin with. They are not very much used in these days. They were used 15 years ago. Pioglitazone is still a valid drug, but it's not very much used. And you have the insulin analogs and insulin. What's ongoing are studies on metformin and SGLT2 inhibition. One study that we are looking forward is the one from New Zealand by Helen Pilmore and co-workers. They are actually including patients with prediabetes, as Esteban told you about, to either metformin or usual treatment. And the endpoint is over a year to see how many develop diabetes or not. We don't know the results, but it will be interesting to see. These patients are including down to a GFR of 30 ml per minute. So these are all patients down to kidney disease stage 3. Then comes the results of the SGLT2 inhibitors. First, the empagliflozin study published in 2015, New England Journal of Medicine. This was a glucose-lowering treatment in type 2 diabetic patients with established cardiovascular disease. And what you all know is that it reduced the combined endpoint of stroke, myocardial infarction, or death by some 14%. But even more so, predefined endpoint of cardiovascular death was reduced by 38%. And the same was total death. And later on, we have received similar data from canagliflozin, another SGLT2 inhibitor, and both these inhibitors also seem to preserve glomerular filtration rate in the long run. An early dip in GFR once you start the treatment. This is canagliflozin, this is empagliflozin, the EMPA-REG study, and then a stabilization of the GFR while the patient is still on ACE inhibitors or A2 blockers. And we are thinking, wow, this would be the perfect drug for a PTDM patient who has high glucose, high cardiovascular risk, and are at risk for reduced renal function over time. So what we did in Oslo, we called the company producing empagliflozin and asked, could we just try to gain forces, maybe across the countries, and start a randomized international control trial on empagliflozin on PTDM patients? Unfortunately, they said no. And the reason that they said no, this was on a high level in the States, was probably that they were afraid that we should screw up all the good results from the type 2 diabetic population. This is a high-risk group of patients, so they didn't want to support that. What we did then was that we made a study ourselves, actually, where we encapsulated empagliflozin and made a placebo pill. And with our budget, we were able to enroll 50 patients, randomized to either empagliflozin or placebo, PTDM patients. As you can see, I don't have the results yet to show you. The last patient out is in June 2018, and I can verify that. I saw that the last patient finished the study Thursday this week. So hopefully by August, September, we will have the unblinded results and give the results of what we're looking at. 50 patients were actually supposed to be enrolled in the study. We managed 46. To reach statistical power, we needed 42 patients. 46 patients have completed the study. They are randomized in a 1-to-1 ratio, either with 10 milligrams empagliflozin or placebo. And we do a baseline investigation with continuous glucose measurements, DEXA, OGTT, 24-hour urine excretion of glucose and whatever, and blood pressure measurements, 24-hour blood pressure measurement. And we do the same thing after 24 weeks. Primary endpoint, weighted mean glucose as estimated from continuous glucose measurements. And we also do the OGTT body composition with DEXA measurements, 24-hour blood pressure, arterial stiffness, estimated GFR, and also 24-hour urine glucose excretion. Hopefully, this will turn out to be a good treatment. In terms of risk, but of 46 patients, 30% of them being women, we have had 4 incidents of lower urinary tract infections. Not more than we would expect for any other kind of treatment. So the signal there is so far that it's safe. If it's working, I don't know before we unblind the study. So to the GLP-1 receptor agonists. We were all thrilled by the leader study with liraglutide, reproduced by another GLP-1 receptor agonist, semaglutide. In the usual combined primary endpoint, a lowering of 30%, 13% of cardiovascular death and non-fatal myocardial infarction and stroke. for cardiovascular death, an even higher effect, 22%, and renal protection as well. Maybe not of the same kind as you see with an SGLT2 inhibitor, because the major difference in the renal endpoint here is on the development of macroalbuminuria, not on the change in creatinine and renal function. But anyway, renal protective. So this should actually also be, as Armando alluded to, a very good drug in our patients. Do we know anything about this? Unfortunately not. To my knowledge, there are no randomized controlled trials ongoing for this type of treatment in post-transplant diabetes patients. There are case reports, first one being this in Diabetes Care in 2013, 4 or 5 patients, combined treatment for 3 weeks with tacrolimus and liraglutide. These were non-diabetic patients. Even so, there were not much difference in the blood glucose, except for postprandial glucose, a little bit lower with liraglutide. A body weight change in those who used the drug in favor of liraglutide, and a lowering of area under curve for tacrolimus in those with liraglutide, which may be somewhat worrying because you may do something with gastric emptying with these drugs and the absorption of immunosuppressive drugs, but we don't know this yet before we have larger studies. The concept would be, at least, that we think that our PTDM patient may have the same defect as you see in type 2 diabetes. This is an old picture, an old study by Miller and co-workers, showing that if you give a carbohydrate-enriched meal to healthy controls, you have a normal glucose excursion, you have a high insulin excursion, and a complete suppression of glucagon in these patients. If you have a type 2 diabetic patient, glucose runs higher, you have a lower insulin response, and you have less suppression of glucagon. This is all due to an impaired incretin effect of the GLP-1 and maybe GIP-1 hormones from the gut. Our question was, do you see the same thing in PTDM patients? So we tried to look at that in a collaboration with Copenhagen. And this was published 2 years ago, and the answer is like you see here. PTDM is also characterized by impaired glucagon suppression and insulin secretion defect during hypoglycemia. We did that with and without a GLP-1 infusion to see if GLP-1 administration would sort of reverse or improve the defect. To show you the concept that we did and the study, we did a hyperglycemic clamp where we clamped blood glucose in the participants at 5 millimoles per liter higher than baseline. These were all patients with, or without PTDM. 12 patients in each group. We studied them on 2 occasions, one with saline, the control thing, and then on another occasion with a continuous GLP-1 infusion over the total period of time. What you expect to see when you increase glucose with 5 millimole per ml and keep it stable for another 2 hours is you expect to see the sudden first phase insulin release, then the tapering of the first phase, and then an increase in the second phase. And physiological suppression of glucagon, of course. So this is what we saw with the saline infusion in the control situation. These are persons without diabetes. They have been undergoing renal transplantation, but they do not have diabetes. These patients have post-transplant diabetes. So we increase the glucose by 5 millimoles per liter and keep it stable for, well, up to 3 hours. You can see a sharp rise in insulin release in the control group and a suppression of glucagon in red. As for the PTDM patients, both things are impaired. They even start at a higher fasting plasma glucose. So we increase by 5, so they are actually higher at this level in glucose than the control group. Even so, the release of insulin is severely impaired, and the suppression of glucagon is also impaired, as you can see from the calculation data that I have underneath here. The maximal suppression of glucagon was 63% in the control group, 40% in the PTDM group, and the insulin increase was several-fold increase, 444%, but only 82% in the PTDM group. Now, what if you do this experiment once more, but then with a GLP-1 continuous IV infusion, like this? Well, we raise the insulin, we raise the glucagon, we raise the glucose with this 5 millimoles per liter above baseline. You have a suppression of glucagon, and you can see that this is even more so with GLP-1 than in the shaded curve here, which was the control situation. You also have a tremendous increase in insulin release. This is the old curve. The scale has shifted now, and you can see there is an increase in insulin release and also some improvement, some improvement in glucagon release. So if we want to summarize what I've been saying right now and go back to the old algorithm, this part up here has not changed. We need to treat the blood glucose post-transplant with insulin the way we've been doing. You can choose to what level you want. The previous level, less than 7.5% in HbA1c, 58 millimoles per mole, stands until we get the answer from the Vienna group. Does lowering glucose more than that prevent PTDM in the long run? But now I would say, if immunological risk allows it, consider to switch from tacrolimus to cyclosporin in light of all the experimental studies that have been performed that we heard of today, and also the late Austrian paper. If needed, start alternative treatment with either a SGLT2 inhibitor or GLP-1 receptor agonist or both. But this is pending documented research from trials. So we have to wait for these trials to be sure that we're doing the right thing. Final remarks. Multi-pharmacy, reduced GFR and cardiovascular risk in PTDM patients preclude extrapolation of research from other groups of patients. Remember that. Treatment strategies should be guided by intervention studies primarily, not by calculated risks. Long-term studies on solid endpoints are unfortunately lacking, and we need them desperately. And this is a challenge, not only to healthcare providers, but I'm saying this also to the pharmaceutical industry that have these possible drugs, that they should support trials also in our patients with high statistical power and long enough time to see if they have the same effect on our patient as they have in type 2 diabetes. That is our future, actually. So I think there's light in the tunnel, at least in winter time in my part of Norway. In the northern part of Norway, there are at least some Arctic lights. So thank you very much. This is a picture from Tromsø.